So let's talk about central nervous system depressants, right? So when we talk about CNS depressants or central nervous system depressants, they generally slow down activity in the brain or spinal cord. And the net effect of a central nervous system depressant is that it reduces inhibition, it reduces tensions. Sometimes we talk about reducing anxiety, helps people sleep, things of that nature. So reducing tension and inhibition. However, it also can create significant problems with judgment, motor coordination, and concentration. So we have to be mindful of how these central nervous system depressants affect you. If you are prescribed something like Xanax or Ambien, they are likely to slap a warning on the bottle that says don't use heavy machinery when under the influence of this drug. Well, the reason why they do that is because they know that it could result in slower reaction time, which could increase accidents. It could result in you falling asleep and so forth. So we do have to pay attention to the side effects of these drugs. So if we were to talk about depressants, the ones that are most widely used are alcohol, sedative hypnotics, and opiates. Now, we are going to see that alcohol and sedative hypnotics generally target GABA as a neurotransmitter. Does anyone remember what GABA or how GABA operated in the nervous system? What is the role of GABA?
Inhibitory neurotransmitter.
Right. It's our primary inhibitory neurotransmitter, right? So if that's the case, when we inhibit inhibition, what do we get? You get disinhibition, right? So you get people doing things that they wouldn't ordinarily do under the influence of a drug, right? So we have to be mindful that some of these drugs alter judgment, decision making, and increase the likelihood of doing an impulsive act. Sure. Muhammad asked, could I explain that again? If GABA is our primary inhibitory neurotransmitter, and we reduce the levels of GABA in your system, or block the GABA neurons from firing, you have inhibition of inhibition, which we refer to as disinhibition. Now, disinhibition on a behavioral level might be the reason why you might find someone who's drinking dancing on top of the bar, or showing poor judgment and going home with someone and then next day asking, well, why did I do that, right? Something of that nature. It's the disinhibition that is going on here. Now, when a person has anxiety, or when a person struggles sleeping, this is a good thing to help them relax, right? So alcohol and sedative hypnotics help people relax. But when it's abuse, it can cause some significant problems. But that's alcohol and sedative hypnotics. Opiates operate very differently than the previous two. When we talk about opiates, we're dealing with a drug that influences the opiate receptors, right? So we have the mu, delta, and kappa opiate receptors. So it's a specific drug. It still is a central nervous system depressant, but it's going to operate differently than alcohol and other sedative hypnotic drugs. So let's go into it. If we were to talk about alcohol, alcohol is one of the most widely used drugs. In fact, 2 out of 3 Americans, or the US population, drink alcohol. Now, that's a large number. When you think about other drugs, you don't have a significant usage rate like this. But it is clear that in the US majority culture, alcohol is viewed favorably. Now, people who are less likely to abuse alcohol are people who have religious restrictions. So if you are Muslim, you're going to be less likely to abuse alcohol, right? Because it is a forbidden substance. If you have extreme negative reactions to small quantities of alcohol, you're going to be less likely to use alcohol. So if you're of Asian descent, you metabolize alcohol differently oftentimes than your Caucasian counterparts, which means that alcohol has a stronger effect on you. And what's you might have heard culturally Asian blush, which is the flush experience in the face that many Asians have. So if we were to look at ethnic differences, Asians are less likely to abuse alcohol. So there are communities within the US population where the rates of alcohol use are going to be lower than other communities. All right. Now, here's an interesting one. We see that about 6%, or 1 out of 16 people who are either 11 years old or older, are considered heavy drinkers. 1 out of 16. Now, the definition of a heavy drinker is a person who has a binge drinking episode at least five times per month. So this person is really putting it away, right? So I didn't define a binge drinking episode, but I'll do that now. A binge drinking episode is to have 4 drinks in a setting if you're female, or 5 drinks in a setting if you're male. Now, why is that? Similar to Asians, women generally break down alcohol differently than men, making lower doses of alcohol in general increase toxicity. So we have to be mindful of that. Now, of the heavy drinkers, we see that the ratio is about 3 to 1. So males are 3 times more likely to be heavy drinkers. So if we were to talk about alcohol, what is the active ingredient that gets you high? Well, we refer to it as either ethyl alcohol or ethanol. This is the active ingredient that goes through the blood-brain barrier and gets you high. It is found in beer, it is found in wine, it is found in hard liquor. Now, are we familiar with the proof system? How many of you are familiar with when something says 80 proof or 100 proof or 151 proof? What does that mean? Nobody knows? Catalina, what do you think the proof system means?
It has to, does it have to do with like the volume? Like it's up to a certain time for by alcohol by volume, I think.
Yeah, so it is the concentration of alcohol in the actual bottle. Now, most people are not drinking uh, heavy proof alcohol, right? The standard whiskey is 80 proof. So when we talk about spirits, right? Generally, we talk about 80 proof, which is 40% alcohol content, right? Bacardi 151 is the reason why I said 151. That is 151 proof, which is over 75% alcohol. Now, naturally, the proof is going to affect your blood alcohol concentration, isn't it? So if I were to speak equivalency, I would tell you that one domestic 12-ounce beer, is equivalent to one 5.5-ounce glass of wine, which is equivalent to one shot or 1 ounce to 1.5 ounces of hard liquor or spirits. So when we say a heavy drinker has, if they're male, 5 drinks in one occasion, that doesn't necessarily mean they actually have to have 5 drinks 5 times a month. If you had 3 double shots of vodka, well, guess what? You had 3 actual drinks, but it's equivalent to 6 drinks because it's a double shot. Does that make sense? And that's already a binge drinking episode. And for females, having 2 double shots would be sufficient. And, listen, if you are in a college environment, the likelihood of you binge drinking is pretty high, right? It's part of the culture in colleges, unfortunately. But that would not make you have an alcohol use disorder. And I would argue that one of the common scenarios where we get heavy drinking is in college because of its culture in fraternities and sororities. So this is something to think about. Now, what happens short term? So when a person drinks alcohol, generally speaking, it helps GABA shut down other neurons to help you relax. But if you inhibit inhibition too much, you get that disinhibition. Now, when it targets the brain, it's also going to target different parts of the brain. The first place it's going to target is your frontal lobe or your prefrontal cortex. Now, when you think of your prefrontal cortex, that is where all of your judgment, planning, decision making is happening. So when a person drinks higher amounts of alcohol, they're more prone to poor decision making. It also targets the memory centers in the prefrontal cortex, which is a problem because that's how you can have people have memory gaps under the influence. It targets next the cerebellum. So if you ever saw a person who is, significantly inebriated or what you would call drunk, you'll notice that they struggle walking a straight line, right? Why is it that they can't walk a straight line? Because alcohol has now targeted the cerebellum. Now, there are GABA neurons in the cerebellum which are responsible for fine motor control and even gross motor control and timing. So the ability to walk a straight line is impacted because of the cerebellum. And then it can also target the medulla, which that is where it gets seriously dangerous because you run the risk of death at significantly high amounts of alcohol, right? So your body will fight back. Your body will try and tell you you've had enough. And I will talk to you about that shortly. But yeah, so if you drink high amounts of alcohol, you can actually cause yourself to overdose and die in principle. So we talked about blood alcohol concentration, or BAC. Now, your blood alcohol concentration is impacted by a lot of different things. The first thing I'll tell you is the size of a person, right? So the heavier a person is, the more they will likely be able to drink. So a smaller person is likely going to have greater effects from the same amount of alcohol, right? Versus a bigger person, it may not have as profound effects. Gender affects alcohol, not just based on the size of a person, right? Because in general, women tend to weigh less than men on average. But it isn't just about the size of a person. There is an enzyme, alcohol dehydrogenase, which is the same enzyme we talked about with Asians, that is responsible for metabolizing alcohol. And women have less of this enzyme, which means that the alcohol builds up more. It doesn't break down the alcohol as much. Thus, women, generally speaking, are more intoxicated than men on a specific dose of alcohol. Now, I said generally speaking. Can anyone create an argument to the contrary before I move on? Generally, the size of a person matters, the gender of a person matters. What's the exception? Let me call on.
Probably an exception would be, let's say, if a woman is like heavier than a man, or like is large, it's larger. Like, does this take?
I want to eliminate the size of a person as a factor, and I want to eliminate the enzyme. There is another issue. There you go, Julia got it. How frequently they drink. If you have a woman who drinks regularly, it's not uncommon for her to develop a tolerance for a specific dose of alcohol, whereas a male, if they don't drink at all, that same dose could result in them getting tipsy or buzzed, or however you want to say it. So yeah, we have to pay attention to tolerance as a factor here as well. All right. Now, when we talk about blood alcohol concentration, we generally see if we have 0.06, that's or 6%, we see relaxation. People tend to become more mellow, and so forth. By 0.09, we have alcohol intoxication. Now, this is an interesting number, right? Because if you were to look at state laws and what is considered the legal limit or being over the legal limit, you're going to see most states have 0.08. If a person's BAC is 0.08 or higher, they're going to be treated as intoxicated. Now, why does the state or many states set 0.08 as their number? Because it's right before that 0.09. You will see some states that have 0.10, and that's because they're saying, well, if intoxication is 0.09, it has to be slightly over the limit, right? So generally speaking, that's why some states have different numbers. But if you want to be safe, stay under 0.08. Now, if a person has a blood alcohol concentration of 0.55 or higher, that person is likely going to die of an overdose. Now, the the good news is your body is going to communicate to you when it thinks you've had enough. So if a person is drinking, they're going to start to feel tired. That's one of your body's way of saying, okay, we're tired, slow down, take it easy, these kind of things. You might also throw up. A person who throws up, that person, the body is saying, okay, you're reaching a highly toxic level. I need to pump the system and throw up, right? And then eventually people sometimes have blackouts or fall asleep altogether or lose consciousness. This is your body's last resort to say, stop drinking. If you won't stop drinking voluntarily, I'm going to shut the system down myself, where you will lose consciousness. Now, this is great that your body does this, but your body is not a perfect machine. If a person drinks large amounts of alcohol in a short period of time, your body may not have realized how much alcohol poisoning there is. And it is, for people like this, these are people who wind up in a hospital, right? With alcohol poisoning, they need their stomach pumped and things like that. So it is a problem. One of the silver linings about alcohol is it's metabolized in the stomach, right? So it is a slower acting drug. So if there is alcohol poisoning, you have more time to react versus someone who engages in injectables. So your time to react for a heroin overdose is much less. So it's going to be broken down in the stomach, but usually things are processed in either the kidneys or the liver. For alcohol, alcohol is metabolized in the liver, and you might hear an alcohol-related disease called cirrhosis of the liver, right? So your liver is going to try and help break down this alcohol, but I got bad news for you. Those of you who think you have a trick to help speed up your metabolism, there is nothing that can help speed up the process. The rate of metabolism is anywhere between 10 to 15% of an ounce per hour. Now, how many of you have heard a trick to sober up? Anyone familiar with some of the tricks that people recommend? What is one of the tricks people recommend to sober up?
Drinking coffee.
Drinking coffee. The reality, good answer, is that coffee doesn't actually help you sober up. It just happens to be a stimulant, which is antagonistic to alcohol. You're just as drunk, but the coffee is creating an illusion that you're more alert than reality. That's one of the issues we have with things like Red Bull and vodka, right? Is because you're being pulled in antagonistic ways that you might think you're more sober than you really are, or more alert than you really are. A cold shower. Yeah, people say if you get a cold shower, that'll sober you up. Has no impact on the liver whatsoever, right? Exercise has no impact on the liver. Whatever you want to say, none of it works. Say it again.
Drink electrolytes.
Well, drinking electrolytes does not help you sober up. It just addresses the dehydration factor, which happens with alcohol. By the way, that brings me to another one of the tricks. If you're at the bar, have you ever noticed the bartender might give a person a glass of water? That isn't going to sober them up. It's going to address hydration issues, but that's about it. And by the way, the electrolytes are better than the water because water just rehydrates, but it doesn't restore the electrolyte balance. But even so, whether it's water, whether it's Pedialyte or anything, Powerade, Gatorade, anything of this nature, it's not going to sober you up. Now, another reason why bartenders will give a glass of water is when a person is throwing them back and they're drinking at a fast clip. It might be just a motor habit. So if you give them a glass of water, they might drink the water and slow down their speed of drinking as a whole. But it does not increase the metabolism in the liver. How about bread? Anyone ever hear the bread one? It's going to absorb the alcohol. No, it's not. It's not going to do anything. So the bad news is that none of these tricks that people say are actually going to help you sober up faster. Water would not decrease the concentration of alcohol in the blood because, again, the liver is what's processing it, not the stomach, right? And not the kidneys. So the water is going to be distilled in the kidneys. The alcohol is going to be distilled in the liver. And it's not going to do much for that at all. Nothing. Greasy food doesn't help. Yeah, that's going to, it actually does help. It's going to help you throw the food up. That's all it's going to help. None of these things. I see a bunch more in the chat, but the bottom line is I want you to know the only way to sober up is time. Wait the time. And if you think that you're sober, you're probably not. So if you've gone above the limit, my recommendation, and this is a public service announcement, is to get an Uber, right? Don't get in a car when you think, oh, I'm sober enough to drive. I'm telling you, I have seen this and I've seen the effects of it. So I'm telling you, either wait it out or get a ride, but do not drive. Now, can you guess your blood alcohol concentration? Can you generally guess that? The answer is no. The only way to have an accurate measure of your blood alcohol concentration is a breathalyzer. And what I will tell you is people didn't do the breathalyzer in the past because it was expensive or they didn't have the tools to do it. Now there is a contraption that you could breathe into your iPhone and it will compute your BAC. So if you really want to know what your alcohol levels are, invest in a breathalyzer. Now, I see in a private message, a person stated that they were in a car accident where the driver was drunk. And I appreciate that this person said that, and they're one of the fortunate ones. How many people lose their life due to drinking and driving? It is a large number. And the vast majority of these people are young people, right? So it's a significant problem we have to worry about drinking and driving. Now, in terms of alcohol abuse and dependence, even though alcohol is legal, and we saw the rates, 2 out of 3 Americans on average are drinking, it is one of the most dangerous recreational drugs around. And we have to be careful because it is one of the drugs that you have the earliest exposure to. So if you were to track longitudinally exposure to drugs, the first drug that people report being exposed to is alcohol. And if I had to give you a number, people on average are starting to drink around 12 years old, 13 years old. but we can see it as early as even 8 years old. Now, you might ask yourself, well, how are these 8-year-olds and 12-year-olds gaining access to alcohol? How is it such a problem? Anyone have a thought how these preteens and teens are getting access to alcohol?
From parents,
From their
like
parents.
behind their back.
Right on. Way to go, Mohammed. The number one source of alcohol is in the house. The parents have a liquor cabinet and they don't track it. So poor parental monitoring of alcohol. If you have alcohol or any substance, it should be in a locked cabinet. And I'm going to get to you in a minute, Eileen. But yeah, the number one source is it's in the home. So they don't even have to try. And I've worked with a teenager who told me that they would drink alcohol and then they would just refill it with water. And because the person isn't, hopefully the adult isn't drinking alcohol so often, they don't even notice it until much later. Or if enough time passes, they won't remember what the alcohol level was. Eileen, you had your hand up?
Yes, I was going to suggest the possibility that oftentimes minors as young as 12 and 13 are getting alcohol from older siblings and or friends, friends, older siblings, as well as, I think this is more with nicotine, but I know that a lot of minors are just easily buying nicotine from basic delis, delis and convenience stores and things like that. Because I know that around the block from my little sister's school, when she was in middle school, the deli around the block from her was busted for selling nicotine to minors, and
Yeah.
there's no way they don't know that they're minors.
Yeah.
So
look at my little
it's really unbelievable.
See,
Yeah.
I feel
No, I agree. Liam, I think your mic was hot. But yeah, so siblings that are older, they might get it for them. Friends might get it for them. There's also a culture of "hey, mister." It's actually a phrase. I think they made either a movie or a show around that phrase, where kids are asking people as they go into a store, "Could you?" You brought up cigarettes. Could you buy me a pack of cigarettes, or could you pick me up a 6-pack? I'll give you the money, which is illegal, right? But it doesn't mean that people aren't doing that. And that is the more benefit of the adult approach, right? From the delis, which are selling it directly to these kids, right? But yeah, we also have fake IDs and things like that. So there are a lot of reasons, but the number one source of alcohol, and by the way, opiates as well, painkillers, are in the medicine cabinet, are in the liquor cabinet. People are just raiding these cabinets, and there they are. I see a question, a direct message, private question. Do some parents tell their children they feel more comfortable for their children to drink in the company of them? Yes. Yes, that is the case. It puts the parents at risk of child abuse, neglect, and maltreatment. If a mandated reporter hears that, they can report the parent for child abuse. So it's not advisable, but you do see this is a subculture where parents are like, I know my kid is going to drink anyway. At least if they're drinking around me, I can observe and regulate. Here's a cool study I actually just came across recently. The idea of drinking alcohol versus sipping alcohol. Now, most research studies drinking alcohol, but what about sipping? So a person is just having a little bit, not a full glass of wine or beer or whatever. There was a study done where they separated out the risk for developing an alcohol use disorder when the sipping of alcohol was linked to some religious practice versus a non-religious practice. And people it was linked to a religious practice actually had significantly lower rates of alcohol use disorder, even though they had exposure as children to alcohol because it was part of a ritualistic ceremony. It was less of a problem, which is a wild study when you think about it, because your body processes alcohol the same, whether it's based on a religious ritual or something else. But cognitively, the way you encode it as I'm doing this to get high or versus I'm doing this as service could be different. So very, very interesting stuff. So final point on it, if you are a parent who is exposing your child to alcohol or other drugs, don't do it. You can really jam yourself up by doing it. All right. So now in terms of the rates, I said alcohol use is a major problem in high school, college, and adulthood. And we're seeing it earlier and earlier. So we can now say middle school and for some elementary school. Now the annual rates, 6% of people in a given year are going to meet the criteria for an alcohol use disorder. And across the lifespan, it's anywhere between 13 to 18%. So alcohol use disorders, 13, 18% across the lifespan. That means roughly anywhere between 1 to 6 or 1 to 8 people are going to meet the criteria for an alcohol use disorder. That is significant. Now, you also see that alcohol use disorders are 2 times more common amongst males relative to females. Now, you might be thinking, hey, wait a minute, I thought you said earlier that males are 2 to 3 times more common. Well, if you go back to the previous mention, it was about heavy drinking, right? So heavy drinking versus meeting the criteria for an alcohol use disorder. Heavy drinking is 2 to 3 times more common amongst males. The diagnosis of an alcohol use disorder is 2 times more common amongst males. So that addresses epidemiology. When we look at ethnic differences, we see Caucasian and African American communities have about 7% rates of diagnosis. Hispanic communities have 9% rates. When we talk about Asians, we talked about the enzyme alcohol dehydrogenase. The rates are significantly lower for Asians. It's about half the rates. So there's a significant drop off. But what's not on the slide is the ethnic community that has the highest rate of alcohol use across the board. What ethnic community do you think has the highest rates of alcohol use disorder? Liam, what do you think?
I'm sorry, could you repeat that?
Which ethnic community has the highest rate of all ethnic communities for alcohol use disorder?
Maybe like Latino or like Hispanic.
I said it's not Hispanic. I said the community is not on this slide. So what are we thinking? Let me go to, I want to call someone I haven't called on. Evan, which ethnic community has the highest rates of alcohol use disorder?
Maybe Native Americans.
Correct. Oftentimes we forget about the challenges that Native Americans face But if we were to think about what it means to have systemic oppression for centuries, and then to be relegated to a reservation and to have dispossession of one's land, the experience is very, very painful. And we do see the highest rates of alcohol use amongst Native Americans or Indigenous Americans. That is correct. So yeah, that's not on the slide, but I think it's important to note. Now, Middle Eastern and Northern African communities have very low alcohol use rates as well. And it isn't based on the enzyme, but it's more based on religious belief sets. So Asians, Middle Eastern, Northern African communities tend to have lower rates of alcohol use. So let's talk about what abuse looks like. What does alcohol abuse look like? Well, a person who's abusing alcohol would say, I need alcohol to do things that I would not ordinarily do without the alcohol. So let's say a person is an executive at a business and their job is to give presentations to stakeholders, or a lawyer, and alcohol is part of the culture of lawyers as well. And they say, I can't do this without a drink. That becomes a problem, right? Because they're relying on alcohol to reduce their anxiety to be able to function. The problem is that through time, eventually the alcohol is going to interfere with their ability to work. It's going to interfere with their ability to engage in social functioning in general. Does that mean that's everybody? The answer is no. You might come across the term functional alcoholic. A person who's a functional alcoholic is a person who still is abusing alcohol, but they're able to go to work the next day, or they're able to, relate to their family or romantic partner. But that's the exception. That's not the norm. When we talk about alcohol dependence, now we start to see the tolerance that we talked about. You need to drink more and more alcohol to get buzzed. Now, what are some of the withdrawal effects of alcohol if you stop drinking? Well, you might have nausea and vomiting. You might have delirium tremens, which we talked about earlier, where you might have the shakes. You might have perceptual disturbances like hallucinations. And this can be fatal, right? So if you don't take a person off of alcohol in a careful way, it can be fatal, something to think about. Now, in a detox setting, the delirium tremens we do see tend to go away within 2 to 3 days, right? What is the long-term effects of alcohol, though? What's the big deal? Well, when we look at it, alcohol is a financial burden on society. And we estimate something like $150 billion of losses to society annually due to alcohol. Alcohol, as I said, plays a role in violence, things like suicide and homicide and assaults, and unintentional accidents, right? So there's a significant problem there. And we have what's called COA, children of alcoholic parents, right? And what happens is the psychological wellness of these children are threatened oftentimes. So there is a long-term effect of alcohol to the person and everyone around them. Biologically, the three conditions that I want you to know about is cirrhosis of the liver, right? I think I talked to you that the liver metabolizes the alcohol. And what happens over time is the liver is going to get scarred, and it's going to get bubbly, and you're going to see this white tissue form over the liver to the point where it doesn't function the way it's supposed to. So I encourage you to just Google what a healthy liver looks like and what a cirrhotic liver looks like. We also have Korsakoff syndrome. Korsakoff syndrome is a form of a dementia where a person who drinks alcohol long term develops a vitamin B deficiency, and that causes memory loss and confusion. So there are gaps in a person's memory. But what does the person with Korsakoff's do? They make things up. So it's not uncommon for heavy drinkers for long term to make up stories to fill the gaps in their memory. And prenatally, we have to worry about fetal alcohol syndrome. So fetal alcohol syndrome is a syndrome, and forgive the typo on the slide, I'll get to it, but where a person is born premature, low birth weight, has a bunch of facial abnormalities such as the spreading of the eyes wider apart, elongated forehead, thinning of the upper lip, sometimes a cleft palate. We have heart defects, and because I recycled the slide, this should not say mental retardation, but it should say intellectual disability. Forgive me for that. Now, fetal alcohol syndrome occurs when the developing fetus is exposed to heavy alcohol use. There is a more, I guess, a more common scenario, which we call fetal alcohol effects, which a person doesn't have all the features of fetal alcohol syndrome, but some of them. So lighter alcohol use could lead to that. But I think at this point, it bears asking the question, well, we know that a person can have fetal alcohol syndrome. We know that a person can have fetal alcohol effects, but what is a safe amount of alcohol for a person who's pregnant? What do you think is the safe amount? Fan.
Zero.
Zero. So your position is there's no safe amount of alcohol. Yeah, that is correct. So according to the Center for Disease Control, or CDC, there is no safe amount of alcohol. And I mention that because you might hear like anecdotes of, oh, my OBGYN said a glass of wine at night is not a big deal, or this, that, or another. The research does not support that statement. There is no safe amount of alcohol. You are putting your child at risk for fetal alcohol effects, or in a more severe case, fetal alcohol syndrome. I'll pose another question that's related. Well, when should one stop drinking alcohol? Eileen, when should one stop drinking alcohol?
I would say that one should really stop drinking alcohol at the point where they grow dependent on it. When
Okay. I'm talking about a person, an expectant mother. This is what I'm talking about.
Oh, I'm sorry, I apologize. Yes. They shouldn't drink alcohol really at all during pregnancy.
Right. So when should they stop?
At the moment they find out that they're pregnant, because
And
before
that is,
then,
this is the
yeah.
exact reason why I asked the question, because the natural response is, I
Right.
stop drinking when I discover I'm pregnant. And the reality is, many people have a lighter menstrual cycle during the first trimester. And the problem is then you have the whole sensitive period of development where all of your limbs are developing and the person is drinking. So the true correct answer to this is a person should stop drinking whenever they're having unprotected sex. If a person is not planning against having a child, they are planning for having a child, right? Obviously, even birth control is not 100%. But if you're planning to have a child, then you know that it's possible that you could be pregnant. So it isn't about when you don't see your period. It's even in the planning phases, you should stop because you may not know for at a minimum 2 weeks, potentially even 3 months later. And then all of a sudden you introduce your child to a whole host of teratogens. Isn't that an interesting dialogue? Because if you would think about it, there are people who would say, what's the big deal? Alcohol increases the mood or whatever. But the reality is it also could increase the risk of birth defects. So let's shift gears. We talked about alcohol. I want to talk about sedative hypnotics. Now, whenever you think of sedative hypnotics, again, they start at one point, end at another because of hyphenation. Low doses of sedative hypnotics sedate a person, or they calm or relax a person. That's why you might hear sedative hypnotics referred to as anxiolytics. But high doses of sedative hypnotics hypnotize you, not literally, but they put you to sleep. So low doses sedate or relax you, high doses put you to sleep. And the two types of sedative hypnotics that we have are barbiturates and benzodiazepines, and both are abused. Now, when we talk about it, the first drug on the market were our barbiturates. And barbiturates, they were used to treat anxiety, they were used to treat sleep problems, and they were developed in the 1800s. And they were used until, I guess, there was the drug revolution when we started to have better understanding of a bunch of different things. Now, barbiturates, like alcohol, are metabolized in the liver. Barbiturates, like alcohol, target GABA. Now, they are taken in a pill form, and usually if you take a barbiturate, it helps reduce the anxiety and, takes the edge off. But higher doses are going to start to put you to sleep, and very high doses can result in respiratory failure and death, right? So currently it's a dangerous profile of a drug. We don't like to prescribe barbiturates. It is still on the market as a last resort for sleep problems, but we have a problem. So let me explain. If you are relying on barbiturates, it has a strong abuse potential. So people are going to become dependent on the drug. They're going to develop a tolerance, which means that they're going to need more and more of this drug to take the edge off or to sleep. And the issue with that is that there is a lethal dose. And as you use more and more barbiturates, you're getting closer and closer to a lethal dose. So when you allow a drug to go to market, you have to look at the effective dose, which is the amount of the drug needed to have the desired effect. And there is an effective dose for 50% of people. There's an effective dose for 95%. So we have all these measures of how much of this drug is needed to have an effective dose. But then we still have to ask the question, how much of the drug is going to result in a toxic dose? And a toxic dose is when you start to have all of these negative side effects due to the drug, significant negative side effects. But a third thing we look at is the lethal dose. And the lethal dose is how much of the drug is needed to cause death. And in order for a drug to make it to market, there needs a therapeutic index of at least 3 to 1. Therapeutic index means that you need 3 of an effective dose to reach a lethal dose amount. That's the minimum. Most drugs have a 10 to 1 range. But the problem with barbiturates is you're getting closer and closer to that lethal dose. So there is a significant problem. We also have to worry about coming off the drug. You're going to have a whole host of rebound effects like anxiety and sleep problems, and sometimes neurological issues like convulsions. So that's barbiturates. The good news is that in the 1950s, we said, oh, there's this other class of drugs called benzodiazepine. And benzodiazepine helps relax people, takes anxiety off. But the therapeutic index is far broader, which means the risk of overdose and death is significantly reduced. It is very hard. I don't want to say very hard. It is much harder to overdose on benzodiazepine than barbiturates in terms of the amount of pills. So benzos were put on the market as an attempt to replace barbiturates. Now, you'll hear benzos referred to Xanax, Valium. These are examples. Similar to alcohol, similar to barbiturates, they target GABA, right? So they target GABA. They're metabolized also in the liver. But the good news is that benzos can help you with anxiety without making you feel tired. So it's a good shift away from the barbiturates, which really can make a person tired. So it is a much safer profile. But does that mean that people are not abusing the drug? Of course people are. We estimate about 1% of US adults become dependent on benzodiazepine. So what, again, this would be called a benzodiazepine use disorder, right? So we have to be mindful of that. The last of the central nervous system depressants are opiates. Now, opiates, as I said, operate differently than alcohol and our sedative hypnotics. Opiates operate based on the opiate receptor. Now, you might hear the term narcotics or opiates or things of that nature, but in general, opiates is a broad class of drugs which include natural and synthetic compounds. If you were to slice open a poppy plant, there will be something that oozes out, a sap of sorts. That is called opium. Now, opium has been and continues to be a powerful pain reliever, and countries have gone to war over opium. If you think of the opium wars in the 1800s, there were several of them between Britain and China. And the goal, at least for the Brits, was to tax and regulate the opium fields, right? So there was this monetary element to opium as well. Now, opium is still used. It is used for religious and ritualistic purposes. It's still out there. Afghanistan is another place that has significant opium fields. So we have to think about that. Now, from opium, you can reduce it further to make the drug stronger and stronger and stronger, right? So from opium, we have morphine. Now, anyone who's had a surgery, you've probably been exposed to morphine, right? It's a derivative of opium, but it was designed to help with pain post-surgery. Now, morphine drips are also used in cancer, for cancer patients, not to treat the cancer, but if a person is on hospice or palliative care, they might say, all I want is a morphine drip to reduce my pain. Then you have heroin. Heroin, historically, has been the most dangerous and the most addictive of the group, and it is a derivative of morphine. Every time you do a further derivative, we have a problem, right? Because it becomes more potent. So heroin is the most potent of the group listed so far. Now, heroin, unlike opium, unlike morphine, which have medicinal value, this is considered the most addictive, and it's considered a Schedule 1 drug. Does anyone know what a Schedule 1 drug refers to? Anyone know? So a Schedule 1 drug, actually, I'll pull back. The DEA, Drug Enforcement Agency, they list it as schedule, thank you, 1 through 5. 5 is the most medicinal value and the least addictive, whereas a Schedule 1 drug is considered the most addictive and the least medicinal value. So heroin is a street drug that is very addictive. Now, this is in the natural opiate family. Let's talk about the synthetic opiates. I talked to you about methadone, right? Methadone was designed in the lab to be a replacement for heroin. Methadone is great because a lot of the blood-borne diseases like TB, hepatitis, and HIV are eliminated when you don't have needle sharing. So methadone is great in that regard. The half-life is longer, which means you don't need to go back to the street, right, for heroin the way you would, because it'll stay with you for 24 hours. Now, the problem with methadone is it's also addictive. So people become dependent on methadone itself. Now, if a person developed an addiction to any of these drugs, we would give them what's called an opiate use disorder. Notice I keep using the language because I'm talking about the drug as a class, but the disorder is called an opiate use disorder. Where does fentanyl fit into all of this? Right, fentanyl is now our biggest problem. Where does it fit into this? Anyone know? Feel free to raise your hand or shout it out.
It's used to treat pain, no?
Well, it can be used to treat pain, but it is a synthetic opiate that has now flooded the drug market. And it is estimated to be about 100 times more potent to morphine and about 50 times more potent than heroin. So a very small amount of this, I think they have public service announcements regarding this, can result in death. 4 grains, they estimate, could result in potential death. So there is an illegal market of fentanyl coming I'm sure if you follow the news coming through our southern border, and a lot of people are dying due to fentanyl. So it's a significant problem. That's where fentanyl is. We will not be seeing fentanyl used to treat surgeries or things like this. There's no need for it, right? We don't need something that potent. It is responsible for thousands upon thousands of deaths per year. Okay, that's where fentanyl is. Now, if we were to talk about how opiates work, right? So they provide pain relief by depressing the central nervous system. They bind to the receptors that usually receive endorphins, right? So if you look at the word endorphin, it's endogenous, orphine, morphine. We have natural painkillers, and endorphins usually are what allows us to deal with pain. So we take a drug, put it into our system, it's going to bind to the opiate receptors that usually endorphins would address, and then all of a sudden we get the intoxication effect, right? So we start to see pain relief. We start to see pinpoint pupils and constipation due to these painkillers, right? So that's some of the side effects. Now, when we look at abuse and dependence, it is very easy to become hooked to heroin. And if a person tries things like heroin or any of its derivatives, you could be hooked after one time. So we see the story is roughly a couple weeks, a person has already developed a pattern of abuse. And because of this short half-life for heroin, you start to develop a quick tolerance and need more and more of the drug. Now, eventually what's going to happen is the person is going to be spending large amounts of money to get their high if they're doing heroin. And then eventually the average person cannot afford their own habit. So they're going to have one of two things happen. If they do not get the drug, they're going to start to go through withdrawal effects, right? So they're going to develop a restlessness, anxiety, dehydration, vomiting, weight loss, right? All of these things which are miserable, right? So the person's going to say, I don't want that. So I got to find another way to get the drug. And I'll talk to you about that shortly. But heroin, which was pleasurable, right? In the beginning, because of these withdrawal effects, they go from trying to seek the pleasure to just avoiding these awful side effects. And if a person wants to see and the impact of heroin, just watch the movie Trainspotting, and it'll paint a picture for you of the effects of heroin, the initial euphoria, and then the pain of withdrawal. But if you don't want to seek those withdrawal side effects, you need to get the money another way. And what we see with heroin and other opiates in particular, it's not uncommon for people to resort to illegal activities to support their habit. So you will see people stealing, and they might break into a place, steal something, and sell it for a fraction of its price on the street so that they can secure their habit. They might also sell drugs and get high off the profit, or they might resort to prostitution. In many cases that happens. So you start to see some significant dependency to the point that people are willing to engage in illegal activity because the withdrawal effects are so bad. Now, the rates are about 1% of US adults become addicted to heroin or another opiate at one point in their life. So I'm going to stop there, and we'll talk in our next class and next video about stimulants, hallucinogens, and so forth. But I think we made significant progress today.